Hi friends, welcome to part 2 of this reading of bone lesions on radiographs for NEET PG. So we have gone through quite a few benign tumors and benign lesions and how to go through them systematically to make a diagnosis of these lesions even if you don't have an idea in the exam. Right, let us look at the next lesion on this X-ray. So this lesion is in the proximal femur. The second thing is in which part of the bone is it? It is very clearly in the epiphyseal region of the bone. There are very few tumors in the epiphyseal region. The few tumors which are in the epiphyseal region include the giant cell tumor, chondroblastoma, some ossifying fibroma, infection. So there are not very many tumors which purely arise from the epiphyseal region, right? So this could be one of three things. One is giant cell tumor, chondroblastoma, or an infection. So this most likely is an epiphyseal lesion. What is a zone of transition? The zone of transition is it is a geographic lesion with a clear margin. However, it is not sclerotic, but there is clear margin. It is a geographic lesion with a clear zone of transition, right? What is a matrix growing? There is nothing. It doesn't look like anything in the matrix, or it is not chondrogenic or not osteogenic. So therefore, remember that this picture does not show anything in the matrix, right? And the fifth thing that we have to look for is any periosteal reaction. Of course, in the epiphyseal region, you don't expect any periosteal reaction, so no periosteal reaction. 6 is size. It's reasonably moderately big in size, so it's about 3 by 3 centimeters in size, and it is not causing any problems to the cortical bone. That is the 7th criteria that we have to see. So looking at all the things, strong possibility because it is in the epiphyseal region, it is very and a lytic lesion, non-expansile. A high probability of this lesion is the chondroblastoma. A high chance is the chondroblastoma. So this lesion is most likely to be a chondroblastoma. So every X-ray doesn't have to be a spotter. You can take a look at all these parameters and make sure that you are picking up or you are heading in the right direction and you don't make any mistakes. So an MCQ has multiple options. You can easily pick one of these options, and if you have confirmed with looking at these parameters. So now let us look at this next radiograph. The first thing that you see in this radiograph, which part of the body it is located. It is in the hand proximal phalanx of the ring finger, right? Once any tumor occurs in the hand, which is the most common tumor in the hands and the feet? The most common tumor of the small bones in the hand and feet is Enchondroma. Remember that it is Enchondroma. The second is what portion of the bone is involved. It is probably the epiphyseal metaphyseal region is involved. And the third one is zone of transition. It looks like it is not permeative or moth-eaten appearance. It looks like there is a reasonably clear demarcation. No sclerotic rim, of course, but there is some clear demarcation. What is a matrix? There is some kind of calcification in the bone. You can call it popcorn calcification. It's not exactly typical, but there is some calcification in the lesion. No periosteal reaction. We cannot see any periosteal reaction. The size is significant. It involves most of the bone, and there is some cortical thinning. What about the cortex? The cortex is thinned down on either side. So there is imminent pathological fracture, or there might even be an undisplaced pathological fracture in this case. So what is the condition? It is Enchondroma. Enchondroma is the most common lesion that occurs in the hand, in the metaphyseal region of the small bones of the hand. It is a chondrogenic tumor. There is some kind of popcorn calcification. It is a clear zone of transition. There is a zone between the normal and abnormal bone. There is no periosteal reaction, and there is cortical thinning. So what are the two syndromes that we know with enchondromas? One is called as the Ollier syndrome. Multiple enchondromas is called as Ollier syndrome. Enchondromas with hemangiomas and phlebolytics is called Maffucci syndrome. What is the conversion rate to malignancy in Ollier syndrome? It is about 25 to 40%. What is the conversion rate of malignancy in Maffucci syndrome? It is 100%. It's a matter of time before one of the lesions become malignant. So this is an X-ray about Enchondroma. This is an X-ray about Enchondroma. Right. So if they show a distal radius X-ray in a patient with closed physis or closed growth plate, expansile lytic lesion in the distal radius, it is invariably giant cell tumor until unless proven otherwise for NEET PG. And if it is a tumor in the small bones of the hand, it is an Enchondroma until unless proven otherwise in the NEET PG exam. So let us start looking at some of the more aggressive tumors. Okay, so you can see here that first, what location it is? Distal femur, right? Distal femur is the location of the tumor. What part of the bone is involved? The metaphysis is involved, right? Zone of transition is not very clear. You can see that there is some moth-eaten appearance here. There are lesions all around. The lesion looks like it has encroached a large area of the medullary cavity of the femur. So there is no zone of transition. Appears like moth-eaten or permeative appearance. So this is definitely a malignant tumor, and you must diagnose one of the commonly known malignant tumors, right? There is matrix, there is calcification, there is bone formation in this thing. So this is of osteogenic potential. Then periosteal reaction is very typical sunburst appearance of the bone. You can see the sunburst or hair-on appearance of the bone. It is seen in many of the malignancies, but it is quite typical for osteosarcoma. And you can also see the Codman's triangle here. In a fast-growing tumor, the tumor pushes the periosteum out, doesn't give the enough time for the periosteum to form a layer or a lamellated appearance or a periosteal reaction. So the periosteum is just pushed out in a triangular form, and this is called as a Codman's triangle. And this is called as a hair-on end appearance. And this is called as a sunburst appearance. These are typical features of a carcinoma. Of course, they are not pathognomonic for osteosarcoma, but they all definitely indicates towards osteosarcoma. The sixth thing that we have to see is the size. It is fairly large, involving a lot of the soft tissue, and it is involved a large area of the bone as well. Okay, cortex has been breached, and we have discussed about the cortical picture, right? So therefore, this is a significant radiograph, very commonly shown in your exams, and this is an osteosarcoma. Don't forget, this is an osteosarcoma. So let us recap. The most common location where osteosarcoma occurs in the distal femur. Where does osteosarcoma occur? In the metaphyseal region. There is usually no zone of demarcation. It is either moth-eaten or permeative appearance. The matrix has osteogenic potential. Then it has the periosteal reaction is typically hair-on end or sunburst appearance, and you have the Codman's triangle, right? And then you have the size is quite large and aggressively fast growing, and the cortex is destroyed. The corticomedullary differentiation is lost. Let us look at this radiograph. This is a flat bone or a pelvis. When a flat bone has an aggressive tumor involvement, it is most likely chondrosarcoma. What part of the flat bone is involved? It is difficult to make out what part of the flat bone is involved, so that does not matter. Zone of transition, it is also not very clear. There is a large outpouching of tumor, but doesn't look like it is penetrated into the pelvis. The fourth thing, the matrix, here is where will clinch your diagnosis. There is popcorn calcification. This is called popcorn or comma-like classification, which is an indication of chondrosarcoma. The fifth thing, periosteal reaction, it's not much. Chondrosarcomas do not cause much periosteal reaction. They are slower going tumors as compared to the osteosarcoma. Periosteal reactions tend to occur in fast growing tumors, and those things that disturb or stimulate the periosteum. The size is fairly large. It's a very large tumor, right? And the cortex also is not significant or not important to look at here. The clincher here are 2 points. One is it is in the pelvis or flat bones. Any tumor or malignant tumor occurring from the flat bone is probably a chondrosarcoma until proven otherwise. The second clinching factor here is the popcorn type of calcification, which is typical of a chondrogenic tumor, and therefore the diagnosis here is a chondrosarcoma. What is the treatment of choice for chondrosarcoma? It is a wide excision. You excise the tumor. It's a slow growing tumor, so therefore the prognosis is far better than an osteosarcoma. Now let us look at the last radiograph that we have here. This is a case of a 10-year-old boy, because the physis is not yet closed. You can see that the tumor is in the diaphyseal region of the tibia. So the tumor is in the tibia. The second thing is it is in the diaphyseal region, right? What are the diaphyseal tumors that we know of? There are only 4 diaphyseal tumors that we know of. One is Ewing sarcoma, second one is osteoid osteoma, adamantinoma, and the the fourth thing is fibrous dysplasia. There are only 4 diaphyseal tumors we know of. So if you have a child who's come with fever, who's toxic symptoms, and who is having a large lesion or a swelling in the tibial diaphysis, very high chance that it is Ewing sarcoma. The third thing is zone of transition. It's not very clear because it looks like it involves a large part of the bone, right? So zone of transition is not clear. It is permeative or moth-eaten in appearance. Periosteal reaction, there is lamellated appearance of the periosteum. You can see layers of periosteum forming. So the tumor is trying to break out of the cortical bone and periosteum, right? And every time the tumor is growing, the periosteum tries to form new bone, and that is why there is a lamellated appearance. This can happen in osteosarcoma also. It is not very specific to Ewing sarcoma, but a typical X-ray of an Ewing sarcoma will have lamellated periosteum, and this is also called as an onion peel appearance. It is also called an onion peel appearance. Right, the matrix, there is some calcification of bone here, so it has some osteogenic potential. Okay, and the sixth one, the size, it's quite large. It is expanding here. The cortex has been breached. So what are the clinching features in favor of the Ewing sarcoma? One, it involves the diaphysis in a young child. So this tumor is very common in the first and second decade, and it's the most common tumor in the second decade, remember that. And second clinching factor is it is in the diaphyseal region. Diaphyseal region has only 4 tumors that can happen: Ewing sarcoma, osteosarcoma, adamantinoma, and fibrous dysplasia. The zone of demarcation is not clear. There is no sclerotic margin, and the zone between abnormal and normal zone is very poor. Then periosteal reaction is in lamellated appearance, onion peel appearance is seen, osteogenic or bone formation is seen. So these are the clinching features in favor of Ewing sarcoma. So the malignant tumors that you can get in the exam are osteosarcoma, chondrosarcoma, and Ewing sarcoma. So if there's a young child, then it's probably an Ewing sarcoma. If it's in second decade, third decade, or fourth decade, probably an osteosarcoma. But you have to go through the X-ray in a systematic fashion, so that even if you do not recognize the X-ray in any way or form, you should be able to clinch the diagnosis. So I hope these 3 videos that we have made for you, for helping you in looking at bone tumor X-rays in the NEET PG exam, is very helpful. Thank you very much. Please do get in touch with me if you have any queries. My name is Dr. Kanan Kumar, and this is Plexus Ortho. Thank you.